I'm delighted to talk about this, which is, I suppose, somewhat of a new departure for macular carotenoid research. Certainly a new departure for me. Maybe it's not pushing the boundaries as much as Jim Stringham's work in psychological stress. But actually, Jim, if you're looking for new subjects in that area, I'd say strongly recommend you avoid parents who bring their 3 children on working holidays. Their stress and cortisol levels will be off the scale, and it won't relate to their macular pigment, I can guarantee you. This overview slide, for those of you who have good macular pigment, you'd probably be able to read it all already. Okay, so 2 quick things I want to tell you about this study. First, this is exploratory. Okay, it's a clinical trial data I'm going to present, but it's designed to, I suppose, allow us to maybe interrogate this area and investigate it in a little bit of detail, because John Nolan has had a huge body of evidence to inform the design of his definitive CREST trial. That doesn't exist for glaucoma. So I certainly wouldn't feel comfortable going into a definitive intervention trial trying to determine what are my primary outcome measures going to be, because I just simply wouldn't know where to even start. So that's what this is designed to do. It kind of builds on a little bit of pilot work I did a couple of years ago. The second thing is that this represents preliminary superficial analysis. For the in-depth analysis, you're probably going to have to wait for the papers that come out. The first is out, well, should be in press in ophthalmology pretty soon. So in terms of what I'm going to talk about today, I'm going to spend a little bit of time just going through the rationale, because, as I said, this is a new departure. It might be a stretch for some people as to why we might talk about macular carotenoids in a condition like glaucoma. To build on that, I'm also going to talk about some of the mechanisms that might suggest that this is an area of research that's worth pursuing. And then I'll go into some of the outcomes of the clinical trial. So first, what's glaucoma? I'm sure there's some clinicians here, maybe some people who are not really very familiar with glaucoma, but it's effectively a neurodegenerative disease of the optic nerve. Okay? Effectively, it has little to do with the macula in that sense. You can see the image here on the left, where we have progressive damage to the neuroretinal rim, the loss of that tissue resulting in its functional consequences, which is blindness ultimately, but usually the progression of glaucoma is understood as a peripheral vision disorder, if you like, very different, almost the opposite, if you like, of AMD, where the AMD pictures usually show this kind of central tunnel area where we have kind of a loss of vision. It's actually the opposite in glaucoma, where we have peripheral vision loss initially, so that the patient is relatively asymptomatic, leading into a small tunnel of vision that's left, corresponding with the fovea. So again, that kind of raises the question, why should we be looking at macular carotenoids in glaucoma? And I'm probably going to go through 3 reasons why I think that we should be, and why, I suppose, what has prompted this research in the first place. And the first is that, I suppose, our understanding of glaucoma, what I've just talked about, is the traditional understanding, that it's a disease of the optic nerve associated with peripheral vision loss. But that's changing. And it's changing because modern technology like OCT is allowing us to probe glaucoma in more detail. So we can see here on the left the ganglion cell complex, for example, which is effectively a way of that OCT uses to measure the thickness of the 3 innermost layers of the retina, the nerve fiber layer, the ganglion cell layer, and the inner plexiform layer. Coincidentally, and then we're doing this in the macular region. The innermost layers is where the macular pigment is co-located. So there's one thing there. If we just looking at an example of an OCT output in terms of the, sorry, I'm not sure what I'm after doing there. In terms of the output, we have this region of macular ganglion cell loss, which is evident in even the earliest cases in glaucoma. This is this is fairly novel work, and to see central losses in a disease that's associated with peripheral vision is kind of somewhat exciting, if you like, from the macular pigment perspective at least. Second reason, I'm sorry to throw Bono in your face, but he's really recently come out of the glaucoma closet, if you like. But the reason you always see him in his shades is because of his glaucoma. And his glaucoma, and one of the strongest symptoms that glaucoma patients complain of, is glare. Approximately 70% in any of the studies you read, kind of certainly more than 2/3, come out as having significant glare disability. The second most common problem in more than half of the patients is dark adaptation issues. So they have problems going from light into dark. A lot of them start to complain about night driving complaints and so on, and the glare kind of doubling up on that. So I mean, those of you who know me kind of know that I've done some background work in glare, not so much as Jim and Randy, but there is a kind of, I think, a reasonable body of evidence now to suggest that macular pigment has a strong role in attenuating glare. This top slide on the right shows a nice improvement in terms of photostress recovery time from Jim and Randy in association with a change in macular pigment. And I'll kind of refer back to this towards the end of my talk. I've done a little bit of work just in normal observers, and again, shown as a consequence of supplementation that we can improve people's glare disability, if you like. So I think that that as a rationale does stand up. And the third reason is that disease itself is somewhat recognized as a potential risk factor for having low macular pigment. AMD, I think the evidence there is quite well established. I've dabbled a little bit in diabetes also. This paper is about to come out, or maybe it's just come out in Retina, where we looked at macular pigment levels in a normal control group versus a range of type 1 and type 2 diabetics. And we see a very clear dissociation, if you like, in terms of the type 2 diabetics, who appeared to have significantly lower macular pigment levels. And if you think about the type 2 diabetics versus the type 1 diabetics, I mean, the type 1s have the disease longer, et cetera. So why would it be more likely to affect the type 2s? Well, they're more likely to be obese. And obesity, as we know, is associated with maybe increased oxidative stress, increased inflammation. So again, that's kind of pointing us in that kind of general direction. Some of you may have seen the pilot work that we did originally, just to effectively just kind of a first cut into the area, kind of see whether glaucoma patients actually have lower macular pigment or not. And the scale here probably doesn't do it justice, but the glaucoma group had a significantly lower macular pigment profile relative to the normal control group. So that's effectively what's prompted this trial. So I suppose hopefully I've given you kind of, some sense of that there is a rationale there. In terms of mechanisms, we need to take it a little bit further. It's not good enough to have a rationale. There should be some mechanistic explanation for how macular pigment might be lost or how it might relate to the disease process in itself. So I'll talk very briefly. I'm only just going to touch on this, but circulatory changes, oxidative stress, inflammatory changes, all have a potential role, and all have kind of fairly recently emerged as factors in glaucoma. Again, this is kind of a relatively new area for glaucoma research, but certainly there is some strong evidence to suggest that oxidative damage has a role in increasing the susceptibility of retinal ganglion cells to oxidative damage. In terms of vascular dysregulation, that's very much a strong feature of what's called normal tension glaucoma. You can see here on the left-hand side an optic nerve head with very much reduced blood flow. You can see blood flow levels restoring after treatment. But vascular dysregulation is itself associated with increased oxidative stress and oxidative damage, leading to increased apoptosis of the ganglion cells. I'll also just briefly mention inflammation in that certain forms of glaucoma, acute glaucoma, angle closure glaucoma, for example, uveitic glaucoma, for example, they're inflammatory conditions in themselves. But there's also some recent evidence to suggest that maybe kind of low-grade inflammation in the background has some kind of role to play in, I suppose, in the pathophysiology of glaucoma, certain types of glaucoma. So onto the trial itself. Hopefully, we've established that there's a rationale and there's potential mechanisms by which it could cause some damage, despite the fact that it's traditionally understood as a disease of the nerve and a disease that causes peripheral visual loss. So the trial here, again, we're not interested in comparing glaucoma patients to normals. We just wanted 88 glaucoma subjects with open-angle glaucoma, no other comorbidities, no history of supplementation. We did some dietary intake analysis, and thank you to Liz Johnson for that. Just put them through a range of structural and functional measures to see what was going on, and also wanted to see what was the quality of life impact of that, because as I mentioned, glare is effectively the main quality of life impact that glaucoma tends to have. I suppose the three kind of main objectives that we listed were to effectively, we had established that macular pigment appears to be lower in glaucoma. We wanted to see what would be the response to supplementation. Can we actually augment it? Then use the structural and functional information to investigate what relationships that might have to macular pigment, and then evaluate the structural and functional response to supplementation. The third one was a very kind of minor goal. We didn't really expect or anticipate a significant effect there. But really, the overall objective was to actually use this information to try and design a definitive intervention, which we could be confident about in terms of, if we're going to invest a significant amount of money, that we do it right. So demographic information, nothing terribly exciting here. Age range was 36 up to 84, median 67. Pretty even mix of males and females. Pretty good visual acuity. All open-angle glaucoma, but a few different types, particularly dominated by primary open and normal tension glaucoma. Actually, I should have mentioned the lutein intake there was kind of pretty consistent with what we've seen in lots of other studies, kind of and very low, kind of at about 0.7 milligrams, I think, per day. So into some of the baseline relationships that we observed. In terms of structure, when we looked at the overall group, the 88 people, not a whole lot going on. Again, trying to throw kind of everything at this. We were looking at the ganglion cell complex was our primary area, but we were looking at everything else. We were looking at peripapillary RNFL thickness, macular RNFL thickness, foveal and parafoveal thickness, looking even at the CD ratio and optic disc rim area, functions of the optic nerve itself, and just seeing what's showing out. But effectively, in the overall group, nothing there. Nothing terribly surprising in that. However, because we had the ganglion cell thickness maps, we were able to divide our group into two based on the level of foveal involvement. And if you look at this diagram here on the right, and if you remember the earlier slides where we had the ring of red loss around the fovea, this person here on the right, we categorized as fovea involved. The damage impinged on the foveal area, if you like. Those on the left, green, their ganglion cell complex thickness was within normal limits in the area surrounding the fovea. So we categorized those as fovea not involved. And here's where it got a little bit interesting, in that I probably should have mentioned the macular pigment levels were roughly equivalent to our pilot trial, about 0.23 in the overall group. So again, on the low side. But when we looked at those with foveal involved versus foveal not involved, we see a striking difference, that those with foveal involvement, i.e. structural losses adjacent to the foveal region, their macular pigment levels are statistically significantly lower at all eccentricities. And allied to that, pretty much everything else is worse also. Their ganglion cell complex thickness is lower, their RNFL thickness is lower, foveal and parafoveal thickness is lower. In other words, they seem to have more severe disease. And that more severe disease seems to be correlated or related with the, associated with having low macular pigment. Just to show you the profile itself of the fovea versus fovea involved versus not involved group. And you can see, again, a very clear dissociation here between the two groups. Those with foveal involvement, their pigment levels are dramatically lower. So this is all kind of relatively exciting, if you like, from the functional perspective, which is something we were probably, initially when we started talking and thinking about this, the functional aspect is what we expected macular pigment maybe to have a more central role in. And in the overall group here, what's interesting is that the level of macular pigment appears to be correlated directly to the level of functional visual field loss. So that's quite interesting. Photostress recovery, no relationship. Visual acuity, no relationship. And I haven't presented there, but there's contrast sensitivity, glare disability. Any of our quality of life measures, none of those showed any direct relationships in the overall group. But again, we broke these down into fovea involved versus fovea not involved. I probably should have stuck in a little graphic there, but we did this for the functional group. We did it based on the central 10-2 field results, which allows us to measure 4 points within central 1 degree. So people who had functional visual loss, visual field loss in that central 1 degree, effectively, we categorize as being fovea involved. And we see a pretty similar pattern to what we saw with the structural data. That these have lower macular pigment, but also associated with that, those fovea involved have they have more severe visual field loss. They have poorer contrast sensitivity under glare conditions. And their photostress recovery time is increased in comparison. Again, no quality of life relationships, which in a sense it doesn't surprise me. I've done quite a bit of work in terms of looking at visual function in normals using questionnaires of various designs. None of them have ever really shown anything. And that's probably because they're not designed to do that specifically. They have many different elements into it. so they're not focused enough, if you like, on the area to be able to do that. We got, I suppose, the best that we could that was available and validated in terms of glaucoma and activities of living, etc. But they weren't sensitive enough to be able to pick up any relationships that might have been there. So what about macular pigment response? Two things I probably should say about macular pigment response. First, we use customized HFP at 3 degrees of eccentricity, 0.25, 0.5, and 1 degree. This is, John has probably found the same, and I'm sure others have found the same, that in older individuals who have ocular disease, it's quite a difficult, it's a challenging test. Okay, so we paid a huge amount of attention to try and get the best quality data that we could, but that resulted in us losing about kind of a third of our subjects. I don't know how that relates to what you found, kind of, or others, but it's quite a dropout in terms of statistical power. That kind of raises some issues. The second thing that I should mention is that of the people recruited to the study, about a third exhibited no response to the macular pigment supplementation. So that's kind of quite a high level of non-responder. So that kind of needs some analysis, if you like, to determine what the reasons for that are. Compliance seemed to be good, so it kind of doesn't need to be an issue there. But anyway, back to the results. Despite the kind of loss of power, we did see a small increase, 0.04 log units at 0.25 degrees, which was statistically significantly different in the active group. No significant changes in the placebo group. We looked a little bit further then just to compare the response of those without foveal involvement versus those who were foveal involved. And the relationship is a little bit stronger. If you like, the magnitude of the response is a little bit bigger in the fovea involved group versus the fovea not involved group, which is interesting also. So again, that might kind of send us in a particular direction when we do design this, the ultimate trial. We also took the step of just looking at responders, because there was only 70% of those on the active formulation who did respond. And that's the central graph here. So you can see on the left-hand side, we have the overall active group. On the right side, we have the placebo group. And there's a bit of a difference there, nothing dramatic going on. But certainly when you look at responders only and you just isolate your analysis to those, there seems to be a little bit of a bigger effect. It's kind of almost up to 0.1 of a log unit of a change. So that's interesting. Comparing them, the responders only versus the placebo, we can see that the statistical relationships are quite strong. So there certainly was a significant increase in macular pigment in that responder group. Okay, it's a little bit, I suppose, shadowed out kind of when you throw in all of the people who didn't respond into it, but that's interesting. So what about the structural and functional responses themselves? As I said, going into this wasn't really a strong priority for us. Certainly structurally, we didn't expect to see anything much going on. And that's really kind of how it panned out. That so far we've seen nothing in the analysis to suggest that there was any significant change in terms of structural parameters in the active or the placebo group. If we looked isolate our analysis to responders only, again, really no changes, no benefits in terms of structural. And no significant change, again, if we just isolated the analysis to those who were fovea involved. But that's not really, I should have mentioned, it's a 6-month supplementation trial with the 10-10-2 formulation. Whether you would expect structural changes at all anyway, even with a huge macular pigment response, is debatable. But certainly over that time period where you're really only getting small levels of macular pigment response, you certainly wouldn't be expecting much to be going on. Functionally, kind of similar. Kind of no significant change in the overall active or placebo and no significant change in the fovea involved group. However, if we look at the responders only, their photostress recovery time did improve. And just a little figure here to show you that. Kind of on the left-hand side, we have the responders baseline in red, follow-up in white. So you can see there's a roughly 25 to 30% reduction in their photostress recovery time. So that's quite a substantial improvement, if you like. The placebo group, effectively no change. In fact, the photostress recovery time in those worsened very slightly. So again, there's something of interest going on there. So just to conclude, I suppose, there's kind of a few main things to have emerged. And as I said, this is really exploratory, so I'm not going to apologize for the fact that we're really throwing everything at it. We're trying to analyze it to death. This is just the superficial findings from it, but it certainly seems that macular pigment is lower in glaucoma, whatever is going on. Added to that, this kind of sheds new light on the fact that those who have foveal or certainly macular involvement, whether that's captured using structural or functional methods, they seem to have lower macular pigment within the glaucoma group itself. In terms of baseline relationships with glaucoma, macular pigment wasn't directly related to the extent of structural loss, whether that's to any of the measures that we've taken. But those who did have structural losses in the center, in the macular area, they do seem to have macular pigment, lower levels of macular pigment. Functionally, the relationship is a little bit stronger in that macular pigment is directly correlated with the severity of visual field loss, and also those, again, with foveal field loss appear to have lower macular pigment. Thirdly, in terms of response, it does seem we can augment macular pigment optical density in glaucoma subjects, despite the structural damage that they may have in the macular region. There were, however, a large number of non-responders, despite good compliance. Magnitude of response is low at this time point. Again, not unexpected. In a cohort of patients kind of at 6 months, certainly the level of response is not what you're getting in a group of young, healthy observers with low macular pigment. So something to work with there, at least. And lastly, then, the supplementation effects, no real structural effects, and the only kind of thing to come out was photostress recovery seemed to improve. Whether that's genuine or not, kind of, we're throwing so much at this kind of for one thing to appear may just be kind of a random finding. Kind of that's something that we'll need to substantiate over time. And I'm hopeful that kind of other labs will maybe take on the glaucoma challenge, if you like. Maybe try and verify our work and see what they can come up with also. As I said, the aim of this is really to design the definitive intervention, which hopefully we'll be looking for funding for next year. But as I said, I think we have a pretty nice data set that kind of shows us some of the directions that we probably should be going in terms of the types of glaucoma patients that we should be prioritizing. Okay. Thank you very much.
Thank you for a really great talk. I suppose with Rena Mackay up here at the back, just generally it shares, glaucoma shares so many characteristics with Alzheimer's disease in that it's neurodegenerative and it's age-related of the optic nerve. Have you, or would you consider looking at cognition? I don't think you did it in the study you've just done. Would you consider adding it into the study you're about to do? Because certainly there's very interesting parallels from what we've heard this morning and other work that's been done.
Yep, I mean, that sounds like an interesting idea. I certainly wouldn't have, coming into this, I wouldn't have thought about Alzheimer's disease when I was thinking about glaucoma. So it's interesting to hear that they have maybe some shared elements. So I think I'd be open to that. We'd have to kind of look at the literature, what's out there in terms of what's putting in some of John's work, and kind of might be useful in terms of informing that. But yeah, I mean, they're as both neurodegenerative disorders, there may well be some commonalities that are worth looking at.
Okay. Next question here.
Yeah, congratulations to a really nice study. I also work a lot with glaucoma patients. I have two questions. First of all, did you an analysis about the visual field loss and the uptake of macular pigment?
Mm-hmm. We haven't looked in detail yet in terms of looking at, I suppose, the extent of field loss versus response and that kind of. But that kind of information is where we're going to go with all of that. We're trying to figure out, I suppose, the important part of here is that we get that kind of in-depth analysis into it. So yeah, no, that's something that we need to do.
And furthermore, do you have thought about that just the damage of the retina due to glaucoma leads to a lower turnover, for example, of oxygen, formation of free radicals? You see, my impression is I deal a lot with glaucoma patients, that glaucoma patients very rare have age-related macular degeneration.
That's true.
And I think that's probably due to the damage of the retina. There is actually, then you lose the macular pigment because there is no need for it. Mm-hmm. Yeah, maybe that's an evolutionary process.
Yeah, potentially. And actually, we don't. This doesn't touch on the, I suppose, cause and effect relationship. Yeah. We don't know whether the lower levels of pigment are a function of the disease, or whether there's maybe some causal role for macular pigment in terms of the structural and functional losses that happen centrally in some patients in glaucoma. So that's a whole body of work that needs to be done in itself, just to look at those that causal relationship.
Yeah, but I like your story, and I will also do the same now.
Okay.
One or two more. One question here, and then go ahead. Glaucoma.
Yeah. Hi, James. Please, what was the diagnosing criteria for glaucoma in this study, and did you see any effect on the different types of glaucoma you included?
We've only analysed primary open-angle glaucoma versus normal tension. So my colleague on this was Professor Colin O'Brien, who's the glaucoma specialist in Dublin. So he would have, he was responsible, if you like, for the recruitment of patients based on, there was set criteria, based more or less on the presence of established field loss that was, I suppose, repeatable and characteristic of glaucoma in association with the characteristic nerve fibre and an optic nerve head damage that you would expect to see in glaucoma. So these were people, most were not kind of newly diagnosed. Most people were established on treatment for a period of time. I think the mean duration was roughly 6 years of having glaucoma. And so what was the second aspect of your question?
My second aspect was, did you see any effect on the types of glaucoma? Because I saw there were about 4 different types.
Yeah, we looked at primary open angle versus the NTG group, which we were keen to have a good representation of both, because there are, I suppose, differences in the two diseases, if you want to characterize them as 2 separate diseases. The normal tension group would tend to be associated more with vascular dysregulation and with central field loss. But when we analysed the data, there was no difference, if you like, there. But again, I'm always kind of relatively cautious, and this is all we've done here, but when you're getting into subgroup analyses, you're asking for trouble, if you like. The power was reduced substantially, and it wasn't designed, if you like, to compare the primary open versus normal tension glaucoma. So I'd be cautious about doing it, but effectively, no, we saw no difference between those 2 groups. The other 2 groups were too small to analyze.
Thank you.
I have a question for you. Could you comment on the performance of the glaucoma patients doing HFP, and did you compare them to any objective method like spectralis?
Yeah, no, we didn't compare them. I suppose one of the key lessons is that a spectralis hopefully going to be coming to my lab in January, in that, yeah, I mean, the measurement was very challenging, and the glaucoma subjects in particular, I don't know how they would compare to the AMD subjects, but certainly they found it quite difficult. The median age is 67, but there were quite a lot of people kind of in the older age group who found it quite difficult.
Just with glaucoma itself might throw some of the assumptions of HFP out in terms of...
Possibly. It's kind of, the traditional understanding of glaucoma is that the central region is fairly well preserved, if you like. But, as we're seeing with the ganglion cell complex losses,
they are foveal involved.
Exactly.
You even said that.
Yeah. So there may be something, some issues there. But yeah, as one of the things I want to do for that definitive intervention trial is to have a spectralis.
Even your 0 point is in a glaucoma area.
Yeah, exactly.
James, thank you for a very clear presentation, and I suppose thank you for thinking a little differently. I think this conference has been successful in that regard. We're all challenging different ideas, so that's great. I'm interested in your non-responders. You conclude that they had good compliance. How did you confirm their good compliance?
Well, it was quite basically done. I mean, it's based on tablet counting and verbal response. They're a motivated group of patients, like the AMT group, so you kind of would expect good compliance. But I mean, glaucoma patients don't comply with their own eye drop therapy. Yeah. So so there certainly is a potential for some issues there. Yeah,
and you haven't done serums, is that correct?
No.
Yeah. Just the one point in terms of, I think there may be a suggestion that the measurement of CHFP is influenced by age in terms of difficulty level. I think Jim Stringham, Randy and I did some work when I was in America looking at measuring pigment in older patients with macular, and they can do a very good job if the right protocol is used. For me, the big issue with CHFP customized is it's not actually the subject; it's the person doing the test. And even I'll be honest, in my own lab, I see some people that are very good at it and some people who aren't. Yeah. And that's the challenge, I think, with that. But just to clarify on that.
Yeah, no, I'd agree in that sense. And actually, I mean, to back it up, we don't have any analysis that the ones that we couldn't get the good measurements on, whether it was related to their age or whatever. But it was, I suppose it was, that's the fact of the study, is that 30% thereabouts we couldn't get a good measurement. I agree. Kind of when you're, I would spend a lot of time just working with the student, if you like, the technician, in terms of what is a reliable and acceptable macular pigment measurement. But you're changing personnel all the time, and certainly there are differences in terms of people's ability to explain the test and work with the patient in that sense.
Yes. And just for the record as well, that also extends, objective spectralis measurements are subject to that type of issue as well. It depends on the technician, and that's why currently, as we speak, I think there's measuring macular pigment routinely in the clinic is not something that's done. And I know Robert Cookling and Richard and others are working towards trying to provide solutions to that, but it's just difficult to do in that clinical setting.
Actually, interesting, in the pilot study 2 years ago, in which we used the clinical device, just the 0.5 eccentricity, that was much easier. That was much more straightforward in terms of the ability of patients to do it, because it was much shorter, much less intense. You're not using the 0.25 eccentricity, so there is maybe some value in that. But when you're trying to explore things like we're doing, you're I suppose afraid of missing out on something.
Absolutely. No, congratulations, James.
Thanks.
One more.
Hello.
Okay, over there.
James, are there any serum biomarkers of glaucoma? I was thinking in terms of complement factors, such as you find associated with inflammatory diseases.
Yeah, there's been a bit of work done the past 3 or 4 years about inflammatory markers in general, and the complement factors have emerged in that. So that's, again, kind of relatively recent addition to the glaucoma literature that needs to be taken into account, and certainly provides an additional potential mechanism by which macular pigment might be affected.
Thank you.